Alright, hey guys. Once again, I apologize for not being in class this week, but I hope you like this little break. So feel free to enjoy the PowerPoint webinar presentation at home in your jammies. So hopefully you guys like this. I tried to get a video recording as well, but unfortunately it wouldn't work. So hopefully that means you're paying attention to the slides and then hearing me, and then we'll need your guys' directives as well at some point, so give you some time to grab that if you don't have it yet. You do, I believe, have the opportunity to pause this at any time. So if you want to stop and take notes or take a break or get up and do something else and come back to it, I believe that you can pause the recording. So if anything is happening too quickly and you need some time to digest it, then absolutely do that and take the time. So Unit 6 is on the cardiovascular system and more specifically the emergencies associated with that system. So we're going to talk about cardiovascular disease. We'll talk a little bit about some A&P, some pathophysiology, and then the cardiovascular emergencies themselves. So we talked about cardiovascular disease as a whole. It is the #1 killer in the U.S., so this is something that's very, very common. You're going to see it very often when you're out your ride-outs and then when you're out in the field. Very, very common calls. And it relates to any disease process related to the heart or the surrounding vessels, so any of the arteries or veins that surround the heart. And I'm sure this part isn't new to you, but there are certain risk factors that increase the chances of someone having cardiovascular disease. And these aren't causes, they're risk factors, which means age, familial history, hypertension. They don't necessarily cause cardiovascular disease, but what's found during research is that people who have cardiovascular disease typically have these things in common. So they are older. They have a family history of some sort of cardiovascular disease. HTN, again, is hypertension, so they've got high blood pressure. Hyperlipidemia means high cholesterol levels. You'll see that word in the field as well. So these people are potentially not eating very well and have high cholesterol. They're smokers. And then your environmental factors like diet. So again, a not great diet, maybe high-fat diet. Obesity, so people who are overweight. Oral contraceptive use, so the birth control pill can alter your cardiovascular system, especially your blood vessels and the chances of developing a clot. Usually older women. Sedentary lifestyle, so people who are not active, who don't exercise regularly, sort of your couch surfers, sitting watching a lot of TV type thing, and then stress. So stress releases certain neurochemicals within your body, and those can then increase the chances of cardiovascular disease. So I know that you guys have talked a lot about the cardiovascular system itself in your anatomy classes, I believe both last term and this term, but just a very quick review. The cardiovascular system includes your heart, the blood vessels, and their primary function, of course, is to deliver gases, so deliver oxygen to the tissues and then deliver carbon dioxide to the lungs to be expelled. We also use the cardiovascular system to deliver chemical messages, so those are your neurotransmitters, your hormones, any type of chemical within the body that's going to tell a certain section within the body to do something. So a muscle to contract or a sweat gland to sweat, that type of thing. And then, of course, the cardiovascular system needs to remove waste products. So I did mention carbon dioxide being expelled through the lungs. So to get to the pathophysiology within the cardiovascular system, the biggest thing that really needs to be brought forth is atherosclerosis, which is plaque formation within the arterial walls. Now, plaque is a hard substance that develops on the inside of the arterial wall. So if you can imagine an artery, a hollow artery, and plaque is forming on the inside of that wall, it's changing the shape and the flow within that artery. So the amount of blood that's flowing through an artery that has plaque is less. So the blood is being sort of stopped by that plaque formation. So the risk of an embolism occurs when that plaque becomes dislodged. So the plaque typically grows on the inside of the wall of the artery, but it can actually dislodge, so it can remove itself from the wall of the artery. If it does that, it can travel within the artery and potentially get plugged up somewhere else. So if the artery that it's in is a very large artery, and the plaque or the embolism floats around in that artery and ends up finding a smaller artery or even a capillary bed, it's likely going to get stuck. And when it gets stuck, it results in necrosis of tissue, so death of tissue. So let's say that embolism happens in the heart, well, it's going to cause an MI, a myocardial infarction, which is a heart attack. If that embolism gets stuck in the brain, that would result in a stroke. If the embolism would get stuck in the lungs, that would result in a pulmonary embolism, or PE. If it were to get stuck, let's say, in the legs, then that would be a DVT, a vein thrombosis. All very, very dangerous and all very life-threatening. So the risk factors for atherosclerosis are really the same as for cardiovascular disease. So again, hypertension, diabetes, hyperlipidemia, which again is your high cholesterol, the sedentary lifestyle, obesity, familial history, and then being male. So if we go into a little bit more pathophysiology and talk about peripheral vascular diseases. So these are vascular diseases, so they're affecting the arteries and veins in the periphery. So the periphery being not central, so not typically the heart and lungs. So the first one there is arterial bleed, which, if you don't speak French, you'll know that it means, or if you do speak French, you'll know that that means arterial noises or arterial sounds. Normally found in your extracarotid arteries, so the big arteries in your neck. And it's sort of a swishing sound that you can actually hear. So the patient gets to hear this. A medical provider could probably hear it if you put a stethoscope on the person's carotid artery. But typically the patient would hear a sort of swishing sound and not know sort of where it's coming from. So there's actually plaque buildup in those carotid arteries, and it's causing the blood flow to be forced through it much faster, causing a swishing sound. And so that, again, is the arterial bleed. The next one there is claudication, and that's narrowing of the arteries in the lower limbs. So narrowing of arteries in your legs, usually in the calves. And I did talk about deep thrombosis, I think, on our first week class in calves. And so the narrowing of the arteries here, again, is not allowing blood to flow appropriately. So if blood can't flow properly, we're going to have consequences. So in this case, we're going to have pain because blood starts to pool and tissue starts to die. So if we don't have enough blood getting to a certain area, we don't have enough oxygen getting to that area, we don't have enough waste products being removed from that area. And with that comes necrosis, so again, dead tissue. Phlebitis is another peripheral vascular disease or complication, and it's usually infection or inflammation of a vessel. This is actually pretty common when you insert an IV into someone and don't use aseptic procedures. So aseptic procedures are procedures that ensure that you're decreasing the risk of infection during a skill. So if I was to insert an IV into any one of you, I would make sure that I cleaned the site with alcohol. I would make sure that it dried on its own. I would be blowing on it. I wouldn't expose that site to contamination from the environment. So I want to make sure that the site is as clean as possible and that the catheter that I'm inserting is clean as well. So if you were to insert a dirty needle, for example, the chance of causing inflammation is that much higher. So if that inflammation or infection occurs in the blood vessel, that's called phlebitis. And the last one there is a pulmonary embolism, which we've talked about as well. So that would be a clot within the lungs. And a clot within the lungs prevents blood flow to a certain area, and if you prevent blood flow, then you're increasing the risk of necrosis in dead tissue. So again, a little bit more pathophysiology. Acute coronary syndromes. So acute meaning right now, so very, very fast onset. Coronary, the arteries within the heart. So acute coronary syndrome, so fast onset syndromes within the heart. So we typically present like an MI. So I'm going to say MI very often. It's just lingo that we tend to use. It means a heart attack. It means a myocardial infarction. And the way that these present are not always the same. So an MI might present with chest pain or chest pressure or chest tightness. So a lot of times patients will describe it like they've got an elephant sitting on their chest, or they have an elastic band around their chest right under their armpits, and it's just squeezing and it's tight. They can't explain it, but it's just tight. It's just heavy. Or they might complain of some tight pain just over their heart, so just left of their sternum. And a lot of times you'll see them sort of grabbing at their chest, and that's sort of indicative of cardiac pain, so chest pain. A lot of times this type of pain, you can't reproduce it, so it's non-reproducible, which means when you ask the patient to cough or take a deep breath or move around, it doesn't make the pain any worse. So these are questions that you want to ask your chest pain patients. Can you take a big deep breath for me? Can you cough? Can you move around? Does it make the pain any better? Does it make the pain any worse? Does it change it at all? And usually if it's cardiac pain, it will not change with any of those, which means it is not reproducible. A lot of times people will also have that pain radiating down their left arm or into their jaw or sometimes even to their back. So that's just indicative of where the occlusion is happening in the heart. So where is the necrosis or where is the ischemia happening? So ischemia is just a term used at the beginning stages of tissue death. So if there's an occlusion, so if there's an embolism or a thrombus or a blockage within the heart, or even a spasm of vessels, so there's not enough blood getting to the heart, it's going to start to die. So the first steps of that is called ischemia, and then we'll move onwards to necrosis. So ischemia is sort of the early death of the tissue, necrosis is dead tissue. So the extent of that necrosis or ischemia will determine sort of how bad the MI is. And then the symptoms associated are different from patient to patient. We'll talk on another slide about the differences between men and women and how they present as well. So the presentation for an MI is very similar to the presentation of angina. So angina is pretty much the same as an MI, except there's no long-term deficit. So there isn't any long-term death of tissue. It's usually resolvable. And then the last point on there is plus or minus ECG changes. So the next unit, Unit 7, talks about ECGs, the electrocardiograms. And people with MIs will typically have changes to their ECGs. People with angina do not, usually unless they've had some cardiac injury in the past. So here we'll talk about a little bit more about angina. So angina will present like an MI usually, but it doesn't mean the patient is also having an MI. So angina is the principal symptom of coronary artery disease. So if you've got something going on in your heart, if you've got coronary artery disease, it's likely that you've experienced angina at some point. So angina is a result of the oxygen supply in the heart not meeting the demand. So again, this is a supply and demand thing. So the body needs a certain amount of blood flow. The body needs a certain amount of oxygen. But the heart, in this case, cannot keep up with that demand. And so the blood vessels start to spasm or lose blood circulation and start to potentially have a little bit of ischemia. And again, angina may precipitate an MI, which means it may lead to an MI, but not always. So many times angina is reversible or treatable. There's two types of angina. We've got the stable and unstable angina. So your stable angina patient, he's going to present typically the same way every time he has angina. So it's usually after exertion or stress. A lot of times in the winter you'll find someone who's out shoveling the snow, develops some chest pain, heads back inside, rests for a little while, and the pain disappears. It goes away. Or you run up a flight of stairs, get a little tightness, and then you sit down and relax, and it goes away. So many times with stable angina, the presentation is similar. So they'll get that tightness or that pressure or the heaviness or the radiating down their arm or into their jaw. But again, it's usually after exertion or stress. And then if they relax, sit down, take it easy, it will go away. Unstable angina, on the other hand, is a little bit more concerning because it's not predictable. So it doesn't always follow exertion. So a lot of times you'll see people who are sleeping and they're woken up with chest pain or pressure. And those ones are a little bit more concerning because the patient hasn't experienced this before, likely. And they don't exactly know how to resolve that. And it may not resolve. So it may be more indicative of an MI. It may not. So there's a change in the expected pattern. So these people are sitting at the dinner table eating dinner, so no exertion, no stress, and all of a sudden they've got pain or pressure. Or they're sitting in the chair watching TV, or again, they're sleeping. So not usually following exertion or stress. And so those ones, again, are a little bit more concerning. So now that we know a little bit about cardiovascular disease, we talk about cardiovascular emergencies. It's those acute onset signs and symptoms where the heart or the arteries and veins associated with the heart are the underlying cause of the patient's symptoms. So a chest pain patient, regardless of whether it's angina or an MI, that's a cardiovascular emergency because we can't always tell the difference. Sometimes with ECG changes in 12 leads, we can tell, but we can't always. So we need to consider those emergencies every time. So when we're looking at a patient and we respond to calls for cardiac emergencies, it's really important that we have a look at our patient. We do that sick or not sick look from across the room before we get there. Do a very detailed initial assessment, again, a very detailed focused assessment. So in this case, we're going to look at their cardiac system probably first and determine what's most important right now, what can I treat, what can I help with, and what might I want to do a little bit down the road. So the cardiovascular emergencies that we're going to talk about in this unit are the MI. So you see here that I've written AMI. And that simply means the acute myocardial infarction, so the acute chest pain associated with heart attack. Okay? So MI and AMI are the same thing. So we've talked a little bit about CHF before. We'll talk a little bit about it again today. You'll notice there's a lot of overlap this term, and there's a reason for that. The more you discuss something from a few different angles, the more likely you are of remembering it and truly understanding it. We'll also talk about cardiac tamponade, cardiogenic shock, aortic aneurysms, hypotensive emergencies, endocarditis, pericarditis, myocarditis, and SYNCLERD, which is gastroesophageal reflux disease, otherwise known as heartburn. So if we look at our typical cardiovascular patient presentation, this is probably what you're going to find. But just like when we talked about anaphylaxis, not all patients are going to present with all of these, but these are your key signs. This is what you want to look for. So CP is my short form for chest pain, and that chest pain doesn't always have to be described as pain. It can be pressure, it can be tightness, it can be discomfort. Every patient is going to describe it a little bit differently, and that's okay. Just know that anything associated with the chest could be associated with the cardiac system. So dyspnea, difficulty breathing, shortness of breath, no breathing. Syncope, which is hopefully from your medical terminology course, this is familiar. Syncope is like a fainting spell, but a gain in consciousness. so short-term sort of things as well. Palpitations are a feeling in your chest of your heart sort of beating a little too quickly. So that's something that the patient feels, not something that you could feel as an assessor. The patient might be tired, they might feel fatigued or weak. A lot of times they're very diaphoretic, so they're sweating so much that the electrode leads from the ECG will not even stick to them because they're so sweaty. So a lot of times you need to wipe them down a little bit before putting them sticking down. And then they also often present with nausea and vomiting, which is the N/P. So your initial assessment, you walk into the house, let's say you've got a 78-year-old female patient sitting at the kitchen table, she's eating dinner, and now she's developed some chest pain. So the first thing you want to do when you walk in the room is do that quick sick or not sick look. Does the patient look sick based on your initial assessment? And then you're going to approach the patient, get your life threats assessed. So what do I need to do right now? Determine her pulse rate, her respiration rate, get your vital signs on board, and then determine whether you need to load and go. So do you just keep that patient around, or can you stay and play for a little while? Can you get a full set of vitals on scene? Can you maybe start some medication? Can you start an IV? Are there things that you could do on scene that will benefit the patient in the long run? So this is a skill that you'll gain over the next couple of years or so, and it'll probably need to take some time after schooling to really understand the benefits of staying on scene versus the benefits of departing the scene quickly. So it depends what the patient needs. If the patient needs the hospital, then you need to go. If the patient needs medication immediately, then you need to do that first. So it really depends on the patient presentation. So we'll get into cardiovascular emergencies. So the first one here is the acute myocardial infarction. And we've talked about this before. So the heart muscle becomes hypoxic, which means it doesn't have enough oxygen, and it's without oxygen for a long enough period of time that it causes death to the tissue, so it causes necrosis. Again, it's caused by an embolism or thrombus. So an embolism is a clot from somewhere else within the body, so it's moved, whereas a thrombus has developed where it clots. It can also be caused by spasm, which we talked about in the respiratory system. So if there's spasm of a vessel, it may occlude that vessel, so the lumen or the tube within the vessel becomes smaller. Or it can be caused by decreased blood flow. So perhaps the patient has had a bleed somewhere else and there isn't enough blood coming back to the heart, or there's too much pooling in the extremities. For whatever case, if there's not enough blood coming to the heart, well, that can cause an acute myocardial infarction. And the location of that infarction will depend on the vessel that's being affected. So there's a number of major vessels within the heart, and if one is occluded, then it will affect that portion of the heart. If a number of them are occluded, then it will affect a number of regions within the heart. And most often, the acute myocardial infarction affects the left ventricle, which can be deadly because that's the ventricle that pumps blood out to the entire body. And again, the signs and symptoms associated with an MI are very similar to angina, but typically a little bit more severe in an MI patient. And I mentioned that we were talking about the male versus female presentation, and when I gave you some descriptors of how a patient usually presents with an MI or angina, I mentioned the chest pain or pressure or tightness, which is pretty typical. Sometimes that will radiate down their arm, down their left arm, or up into their left jaw, sometimes through to their back. The trouble is that when you have a patient who doesn't present this way and you're still concerned that it might be cardiac. So females typically present a little bit different, so they're not so textbook. A lot of women will just say they just don't feel right. I'm just not sure what it is. I feel something. It's just kind of funny in my chest. I don't know what it is. They're not the typical textbook presentation of chest pain, pressure, or tightness. A lot of times diabetics are also the same. They can't always pinpoint what the issue is. So you've got to take sort of the patient presentation, how they're describing their discomfort, along with your assessment. So your assessment of vital signs, of their ECG rhythm. Take all of that into account to determine what it is you're dealing with. So next up is CHF. So we talked about CHF. I think probably every class until now. It's where the heart can't pump forcefully enough to empty its chambers because the heart muscle itself is damaged. And it causes blood to back up into both the systemic and pulmonary circulation systems. So when it pumps back into the systemic circulation, we get some blood pooling into the extremities, into the liver, the lungs, sometimes the jugular veins. And then in the pulmonary circulation, we get fluid backed up into the lungs, which results in the crackles that we hear on auscultation. So here's a quick video here. Oh, the sound is not working.
Of the heart called the left. A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster, and the ventricle may increase in size, becoming an even less effective pump. When the kidney sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
All right, so hopefully that gives you a better idea with a little bit of a visual in terms of what CHF really is. If you're still not understanding what CHF is, and talk to me either in class and email or post something on D2L and we'll sort of try and iron out what the issues are. It's very important that you understand CHF. So here's a little bit more detail on CHF. So I think you've talked about this in your anatomy classes, but there's a difference between left-sided congestive heart failure and right-sided congestive heart failure. So left-sided is when the left ventricle is affected. So there's left ventricle damage. And that can be caused by an MI, it can be caused by hypertension, or there can be some sort of congenital abnormality. So it could be an abnormality that you're born with. It can result in cardiac asthma. And I don't know if I've used the term cardiac asthma with you yet, but I have talked about wheezing in a CHF patient. So most often you'll hear crackles with a CHF patient because blood has been pushed from the systemic circulation system into the pulmonary system. So that blood has been backed up and pushed into the alveoli, so into the lungs. Right before there's fluid in the lungs, you get narrowing of the bronchioles because of high pressures. So the high pressures in the lungs, as a result of that, the pressure of the fluid being pushed back in, can cause wheezing. So a lot of times you'll find a CHF who's wheezing, and you start to give them some Ventolin to sort of alleviate that wheeze. And as soon as you open them up, the fluid has somewhere to go. So the fluid now fills their lungs. Not that you've done anything wrong, but you need to be aware that a patient with left-sided CHF could be wheezing, but it's a precursor to the fluid that's about to fill the lungs. So again, blood is pushed systemically from the capillary beds that lie across the alveoli into the alveoli and bronchioles, and that's what you're hearing when you auscultate, so the bubbly crackles. So as if you're blowing through a straw into chocolate milk, into something a little thick, that's what you're going to hear, that bubbly crackling sound. So your signs and symptoms with a CHF are, you're going to see hypertension, you're going to see tachypnea, which is fast breathing, tachycardia, fast heart rate, hypoxia, so low oxygen saturations, possibly some cyanosis, and possibly some frothy sputum. So if there's enough fluid in that patient's lungs, they're going to sort of start like foaming at the mouth. That fluid is going to come up through their trachea and out their mouth. And it can be a little pinkish as a result of broken blood vessels. So treatment for these patients we've already talked about will be oxygen, CPAP, and nitro, provided they fit the medical directives. So right-sided congestive heart failure is when the right side of the heart is affected, and it results from left-sided congestive heart failure. It's where the right side of the heart can't keep up with the workload because the left-sided is so damaged. The left side is so damaged. In this case, blood backs up into the right ventricle and then systemically. So this is where you get the blood pooling in the extremities and in their jugular veins and in their organs. So right-sided failure is not usually the life-threatening emergency. It's the left-sided failure that is, and that usually results in an MR. So moving on to cardiac tamponade. This results when you've got excess fluid in the pericardium. So the pericardium is a fluid-filled sac that surrounds the heart, but the amount of fluid that surrounds the heart on a normal basis doesn't cause any issues. So it's just enough fluid to prevent two layers from sticking to each other. It allows the heart to expand and contract fluidly without constraint from an exterior wall. But if for whatever reason there's too much fluid in the pericardium, we have a cardiac tamponade. And it limits the ability of the heart to expand after each contraction. So as the heart is filling with new blood, it can't fill as much as it normally would have because there's additional pressure from the outside because of that fluid. And so the signs and symptoms of someone with cardiac tamponade include a narrowing pulse pressure. So if you don't know what a pulse pressure is, it's the number difference between your systolic and your diastolic blood pressure. So if your normal blood pressure is 120 over 80, the difference between 120 and 80 is 40 points. Someone with cardiac tamponade, that point difference is going to get smaller. It's going to narrow. So if you're on your initial assessment, the patient's blood pressure is 120 over 80, which is unlikely, but it's going to be easier to say like this in the presentation. It's 120 over 80, and your pulse pressure at that point is 40. Your next blood pressure might be 110 over 80, where your pulse pressure would then be 30. And then your next one might be 100 over 80. To see how that gap is getting smaller and smaller, that's called a narrowing pulse pressure. So normally your systolic blood pressure will lower, whereas your diastolic will stay about the same. So that's something that's very important to note in any patient that's having chest pain. You'll notice the patient will also be tachycardic, so they'll have a fast heart rate. And then they have something called Beck's triad. Now, some of this you can assess for, some of it you might have difficulty doing. So Beck's triad includes JVD, so your jugular vein distension, so excess fluid in your jugular veins, so you'll see that in their neck. They'll be hypotensive, which means you have low blood pressure, and they may have distant heart sounds. Now, paramedics are not exactly the best at listening to heart sounds. It's not something we do very often, so it's not something we're good at. So knowing whether a heart sound is distant or close, it's not really a skill we have, unless you've been taught by a cardiologist really how to do that. And then the treatment for cardiac tamponade is pericardiocentesis, which is not something we can do as medics. It's something that's done surgically. So this is where a needle is inserted into the heart sac that surrounds the heart, the pericardium, and that fluid is removed. So your treatment for this patient is really just transport. So moving on to cardiogenic shock. So cardiogenic shock is when the heart is so severely damaged that it can't pump enough blood to maintain tissue perfusion. So if you don't maintain tissue perfusion, you get tissue necrosis. So there's a high mortality rate in patients like this. They die very, very quickly without intervention. So the signs and symptoms are severe, and it's the same signs and symptoms that are associated with the MI. So I'm going to give you a second to pull out your protocol books, your medical directive books, and find your acute cardiogenic pulmonary edema medical directive. So again, you're looking for the acute cardiogenic pulmonary edema. Oh, no, I lied. That's not the directive you're looking for. You are looking for a cardiogenic shock medical directive. Sorry. So let's start that again. You're looking for your cardiogenic shock medical directive. I'll just give you a few seconds to find that. Okay, so hopefully you found it. It's on page 38 if you're using a little medical directive book. So we're going to go through the medical directive for cardiogenic shock. Now, this is a little difficult because you need to be IB certified. So you won't be practicing this in your clinical setting as a student, but you should be aware of it. So if you look at the indications for cardiogenic shock medical directive, you need a patient that is STEMI positive and in cardiogenic shock. So I doubt at this point that you know what that means, and that's fine. So here's an introduction to it. So STEMI positive ECG. So we're going to talk about ECGs in the next few minutes. So the electrocardiogram is really just the electrical activity within your heart and how it presents itself in a chart on a piece of paper. So that's your ECG. So STEMI positive means that you have ST elevation MI. So an MI, so myocardial infarction, has occurred in this patient, and the reason we know it is because we have ST elevation. So ST is a segment within the ECG, and it is elevated. It simply means that there's a change in the ECG, and it's showing that the patient has had an MI. So your cardiac monitor will say this patient is having an MI, period. So as long as the monitor says that, and the patient is demonstrating signs of cardiogenic shock, then the patient fits this medical directive. So signs of cardiogenic shock include hypotension, tachycardia, decreased level of awareness. So anytime we think a patient is in cardiogenic shock and they have those ECG changes indicative of an MI, they can be treated using the cardiogenic shock medical directive. So if you look down to the next section, into the conditions section, the conditions in order to receive 0.9% sodium chloride, which is our saline solution, the patient needs to be at least 2 years old. The patient has to be hypotensive. So in the case of the sick patients that we're referring to in the medical directive book, that means they have to have a blood pressure, a systolic blood pressure of under 90. And we also have to have a clear chest. So in our lecture yesterday, we talked about signs of fluid overload. And signs of fluid overload are found in patients that have fluid in their lungs. So in this case, the patient cannot have fluid in their lungs because that would be a sign of fluid overload. So this patient needs to have clear chest status, so clear chest on auscultation. So no fluid in their lungs. And there's no contraindications for this medical directive. If you flip the page over, page 39, it'll tell you the treatment for cardiogenic shock. So in both age ranges, so patients 2 to less than 18 in patients at least 18, we're going to infuse fluid. So your saline solution at 10 mils per kilogram to max volume of 10 mils per kilogram. So what I want you to do is take your weight and figure out how much fluid you would get. So I'll give you a couple minutes to do that. So keep in mind you're getting 10 mils per kilogram. So in our last lecture, we talked about the IV fluid management medical directive. And when we talked about that one, the rate of flow was 20 mils per kilogram. In this case, for cardiogenic shock, it's half of that. It's 10 mils per kilogram. So if you had a patient who weighed 50 kilograms, so about 110 pounds, you'd be giving them 500 mils. So again, your patient was 50 kilograms, they could get 10 milliliters per kilogram. So 10 times 50 is 500. So they could get 500 milliliters of saline solution. And then again, same reassessment as the IV fluid therapy, medical therapy, for patients aged 2 to 18. You're going to reassess that patient every 100 milliliters. And for patients at least 18, every 250 milliliters. And then there's no clinical considerations for that medical directive. So again, overall, the cardiogenic shock medical directive, we need to know that the patient is having an MI. So they're having a heart attack right now. And the reason I know that they're having a heart attack right now is because my cardiac monitor has said so. It's been an indication that there's a certain change to their ECG, and I know that they have an MI. Right? They also need to be cardiogenic shock, so they need to be hypotensive, tachycardic. They need to be showing signs that they're having a cardiac emergency. They need to be at least 2 years old. They need to be hypotensive, so blood pressure of less than 90, and they need to be clear on auscultation. So if they need all that, I'm going to be giving that patient 10 mils per kilo and reassessing either every 100 mils for patients 2 to 18 or every 250 mils for patients over 18. All right, so moving on. Another cardiovascular emergency is the aortic aneurysm. So an aortic aneurysm is a bubbling or a dilation, an outpouching of a blood vessel that may rupture. So there's a couple diagrams on the slide there, so have a look at those. The most dangerous aneurysms are those found either in the thoracic cavity, which is your chest cavity, or the abdominal cavity, which is your abdomen, your stomach area. So the diagram on the left is the thoracic aortic aneurysm, and it's found on the aorta as it leaves the heart. So imagine a bulging of the aorta, and imagine it rupturing. So if it ruptures, there's a certain amount of blood leaving the heart that's not going to get where it needs to go. Okay? And then if you look at the diagram on the right, you'll see the aortic aneurysm in the abdominal area. Now imagine that one burst. That would mean that any blood coming to that area would not be making it to any of the lower extremities. So no more blood is going into the legs. So aortic aneurysms are caused by changes or degenerative changes in the wall of the aorta. So it could be the aorta feeding the heart or the descending aorta in the abdomen. So there's such a change that happens in the wall of the aorta that it becomes weak, and it starts to grow and grow and grow. So if the patient has high blood pressure, that's likely to grow even faster. So the signs and symptoms of someone who has an aortic aneurysm that has ruptured or is close to rupture is a sudden onset pain. So it depends on where the aneurysm is. If it's in the chest, then the pain will be in the chest. If it's in the abdomen, the pain will be in the abdomen. And again, the pain is non-reproducible. So we talked about the cardiac pain associated with angina and your MI not being reproducible. So when you move around, you take a deep breath or cough, it doesn't change. The pain here doesn't change either. This pain, though, is usually sort of tearing in nature, and it sometimes radiates straight through to the patient's back. One thing that you can look for if you're suspecting a thoracic aortic rupture is that you can look for differences in blood pressures from the left and right arm because of how the blood leaves the heart. And that's something that I can show you sort of on a blackboard in class. So again, if thoracic arch is involved with them, that's where the rupture is, and you might find different blood pressures in the left and right arms. So something you can look for. If someone has a ruptured aortic aneurysm, they're going to decline rather quickly. Imagine the amount of blood that's leaving the biggest vessels in your body and not reaching your heart and your brain and your lungs anymore. So they're rapidly going to decline and they're going to die fairly quickly unless there's surgical intervention. So all that we can do as medics is provide fluid therapy and try and replenish some of that fluid and do therapy. Drive as quickly as possible to the closest emerge. All right, moving on. The next cardiovascular emergency is the hypotensive emergencies. So hypertensive emergency really is just severe hypertension, so very, very high blood pressures. Defined technically is 140/90, but typically in a hypertensive emergency, you're going to see numbers much higher than that. Because the blood pressure can be so high, it can lead fairly quickly to an MI or congestive heart failure or a cerebrovascular accident, which is a stroke. So if you think of the amount of pressure that's occurring as a result of hypertension, so let's say the patient with a pressure of 200 over 110. The demand on the heart becomes so high that the heart can't keep up for very long. Or the demand on the vessels within the rest of the body is so high that the vessels rupture. So in the case of a stroke, a patient who has such high blood pressure, they may blow a vessel in their brain. It may result in a stroke, and it's quite common. It's usually caused by arteriosclerosis or atherosclerosis. And the signs and symptoms that you're going to see are a headache. So imagine all that increased blood flow, the increased pressure going to your head, probably going to cause a headache. It can cause dizziness, weakness, epistaxis, and blurred vision. So if you don't know what epistaxis is, simply a nosebleed. However, it's not a simple nosebleed. So if you've got too much pressure, the ruptured vessels are going to bleed. And the capillaries in your nose are more susceptible to that, and you'll often see a nosebleed in these patients. And then I believe this is the last slide. The last of the cardiovascular emergencies include inflammation of the layers of the heart. So if we look at the layers of the heart, we've got the endocardium, the pericardium, and the myocardium. So inflammation in each of these layers results in endocarditis, pericarditis, and myocarditis. So the endocardium, or endocarditis, is inflammation of the endocardium, and it's usually caused by bacteria. So it often involves the valves in the heart, which is why physicians will hear usually a heart murmur in these patients. But because it's caused by bacteria, another sign or symptom that we see in these patients is fever. In the case of pericarditis, so you've got inflammation of the pericardium, And there could be no cause at all, which is what idiopathic means, or it could be caused by a virus. So again, we might see a fever. These patients might experience chest pain, usually sharp in nature, and they may present with tachycardia, hypertension, and ST elevation. So we'll talk about ST elevation in the ECG unit. So don't stress about that just yet. And then finally, we talk about myocarditis, which is inflammation of myocardium. So the myocardium is the muscular layer of the heart, and that's usually caused by a virus. So again, we may present with fever. Again, more of a static, sharp chest pain for these patients. They may present with congestive heart failure, and again, palpitations. And palpitations, again, is that feeling of rapid heart rate. And that's the end of Unit 6. So hopefully that wasn't too quick for you guys. If it was, or if there's any unit or discussion or topic that wasn't clear, post a comment or a question on the discussion board in D2L, and I'd be happy to check it. I'll check that while I'm on the way. So don't feel like you're being completely abandoned. I will absolutely check in there. I'll answer emails. I'll answer discussion posts. So take your time. Obviously, this did take 4 hours to teach because we didn't have a whole lot of class discussion associated with it. So let's take that class discussion that would normally happen in class and let's put it online. So bring up the questions on D2L. I would prefer you put them there. That way the entire class can benefit from the answers. And we'll go from there. So again, please feel free to post your questions, post your comments, ask each other stuff, ask me stuff. I don't mind at all, and I actually prefer that. I'd like to know that you guys are understanding the material. And unfortunately, doing it this way, I can't see whether you're getting it or not. I can't check in as much. So let's do that on D2L. So please, let me know if you have any questions.